Good morning, everyone. I'm Dr. Tara Kieran. I'm a family doctor at St. Michael's Hospital and also the Vice Chair for Quality and Innovation at the Department of Family and Community Medicine at the University of Toronto. I'm really pleased to be the moderator for this session that we've co-organized our department together with the Ontario College of Family Physicians. To that end, I'm going to turn it over to Liz McGaugh, the president of the Ontario College of Family Physicians.
Good morning, everyone. We're delighted you're here to join us. Thank you, Tara, for that introduction. These are the panelists that we have today. Really excited to have them join us again as part two of the conversation we started last week. You'll see the details there about the main pro certification. And I'll just give the land acknowledgement and then hand back to Tara. We acknowledge that the lands on which we are hosting this meeting include the traditional territories of many nations. The OCFP and DFCM recognize that the many injustices experienced by the Indigenous peoples of what we now call Canada continue to affect their health and well-being. The OCFP and DFCM respect that Indigenous people have rich cultural and traditional practices that have been known to improve health outcomes. I invite all of us to reflect on the territories you are calling in from as we commit ourselves to gaining knowledge, forging a new culturally safe relationship, and contributing to reconciliation. And I'm calling in from Ottawa, which is Algonquin and Anishinaabe territory. I'll hand back to you, Tara.
So I always find the land acknowledgement an important time to reflect on injustices past and present. And we know that there were many injustices perpetrated towards Indigenous people also by the medical community, and that there are real reasons for Indigenous people to mistrust us. And I thought this recent article from the Toronto Star highlighted that, highlighted the reasons for mistrust, not just among Indigenous people, but also Black community, the members of the Black community and other peoples of color, and how if we are really going to try and build a vaccine confidence and address vaccine hesitancy, we need to address some of their concerns and fears. Next slide. So we're of course delighted today to bring together a great panel to talk about the vaccines. We've been running these sessions since April, and we are going to be doing them more frequently in the next couple of months. I wanted to highlight that our past recordings, including the recording from part 1 last week, are available on our website, and they are now accredited through a self-learning program. So if you watch them and go through the module, you will receive main pro credits. This specific module, this session will also be there on Monday. Next slide. Just want to shout out to our planning committee who does select the speakers, and we're always open to suggestions, and you'll be getting an evaluation at the end of the session for that. Next slide. So I'm delighted to bring together our panelists, the same panelists we had last time, for whom I know you had so many questions, and we look forward to answering them today. Next slide. As well as our usual co-hosts, Liz McGaugh and David Kaplan. Next slide. I'm going to turn it over to each of our panelists to introduce themselves and speak to their conflicts of interest. Hugh Boyd, can you go first?
Hi, my name is Hugh Boyd. I'm a care of the early physician working in the Hamilton area and Guelph area, medical director at 2 Homes, chief of staff at a small post-acute hospital. I get paid by the OMA, St. Josephsville and Alexander Place, and St. Joseph's Health Center Guelph, and I should probably put OHIP there. But I don't meet with or work or partner with any pharmaceutical companies or device companies. Thank you.
Thanks. Zainab?
So I'm Zainab Abdurrahman, an allergist and clinical immunologist. I work in various areas in the GTA, mostly in Mississauga, but I'm also have a pediatric vaccine allergy clinic at McMaster Children's Hospital, where I'm affiliated with the department. I have many financial declarations, which are all listed below, mostly regarding payments for honoraria and speakers bureau. And in addition, I'm also the chair for the section of allergy and clinical immunology at the Ontario Medical Association. So I should probably put that also, the OMA, as a financial sponsor. Thank you.
Thank you. Noah?
First mute fail. Hi, everyone. I'm Noah Ivers. I'm a family doc at Women's College Hospital. I usually spend my time running a research program in something called implementation science, which is like quality improvement science. I'm actually supported to do that with a Canada Research Chair, so I guess I should put the federal government. I have grants from CIHR and the Ministry of Health, and in the past have done some evaluation consulting and speaking with a few different firms listed there.
Next slide, Liz.
Yep, Liz Mugga, family doctor in Ottawa, president of the Ontario College, and have no relationship with financial sponsors. I have a stipend that I receive from the Ontario College for my work.
David.
Hi, I'm David Kaplan. I'm a family doctor in North Toronto and the chief of clinical quality at Ontario Health, who pays me as an employee, and I receive honoraria from the Ontario College. And after our last session, I wanted to make sure that I could also say that I don't directly own any stocks of any of the vaccine companies that we're talking about this morning. So I went to make sure. I think that's actually probably important for us to think about too, if we own substantial holdings of any of these vaccine makers.
And so, as mentioned, I'm Dr. Tara Kieran. I'm a family doctor at St. Mike's and the Vice Chair for Quality and Innovation at the University of Toronto. I am a researcher and supported by salary, and also have a number of grants I've listed here. The only one from a for-profit company is Gilead Sciences for a study on hepatitis C. Next slide. So we're excited to have all of you come together with us from a course across the GTA, but well beyond. I think we have about 1,000 registrants for the session today, and I know already tons of questions. Next slide. So I see that participants know how to interact on this session already, because we've got lots of questions in the Q&A, and that is definitely our preferred place for you to put your questions in the Q&A box. Our panelists will be answering some of the questions live and some of the questions typed. We'll get to as many questions as possible, but because there are so many participants, we're not going to be able to get to all of the questions, but we'll do our best. If you can put a thumbs up to a question that you've already seen, we find that really helpful, because then that way we can prioritize questions that many people have together. And if you didn't find the answer to your question today, we will be looking at the output and trying to put together resources for family doctors to address those, and stay tuned for more of that on our website. If you have something that you want to share to the audience, please put it into the chat box. So I'm going to turn it over to our panelists shortly, and I know we already have a number of questions and we will be getting to that, but I wanted to start with a discussion about what's happening in long-term care. So next slide. As many of you, I get a lot of my news from Twitter these days, and you know, I've really been following Nathan Stahl closely, because every day he posts what's happening in long-term care. And, you know, it's tragic that 2/3 of Ontario's COVID-19 deaths have occurred among long-term care and retirement home residents. And what we see on this graph is that the number of cases in COVID are just skyrocketing, both in staff and in residents. We have a large proportion of homes, I think something like 40%, that are currently in an outbreak situation. Next slide. But we also have the hope of the vaccine. And, you know, I saw this on Twitter yesterday, and I think this was pointed out, was one of a couple of studies that have now come from Israel. And Israel is the fastest country on the planet in terms of being able to vaccinate its citizens. What we are starting to see is the effect of the mass vaccination. So 14 days after the first shot, infection rates fell by 1/3 among 200,000 60-year-olds who were vaccinated versus 200,000 who weren't. I believe there's a similar study from another HMO in Israel that had it about 50%. And we can see here that there are very, very few reported side effects. So we've got an effective treatment to help us end what's happening in long-term care, but of course only if we get, as we say, needles and arms. So I'm going to turn it over now to Hugh Boyd, who's going to tell us a little bit about what's happening in long-term care in terms of getting the vaccine to the residents and staff who need it.
Thank you very much. This is an important time, and we knew that we had great difficulties and tragedies during wave one, and we're seeing it yet again. And as of the 13th, 198 long-term care residents have passed away, and 2 long-term care staff have passed away from COVID-19. So this is going to be way worse. So I thank the panelists here and all those attending as well for supporting our healthcare system during this difficult time. It's been very difficult to kind of hear priorities being put on something. We live in Canada. We don't like to think of, prioritizing one group over the other. But I'm very grateful that we have some evidence and science-based decision-making here. It's turned out to be a lot more difficult than we anticipated. Grateful for the vaccine to come out, and grateful that the also evidence is guiding the decisions to prioritize those high-risk areas, those in the gray zone first, and then rolling out from there. And as we heard on Wednesday, a target of having these vaccinations in long-term care done by mid-February. Huge, amazing work going through with this. We've got allies here as well. Dr. Ivers has been a long-term care ally supporting quality for many years. Dr. Kaplan is literally putting vaccines in arms. Zainab's been amazing locally in the Hamilton area, supporting us with questions that our long-term care docs have. And just so thankful for people mobilizing to do this. It was tricky. There's a special EMR the Ontario Health is using to document this vaccination. And so there's a whole team that has to support this. So they really jumped to get the vaccines in arm, as they said. And we've seen pictures of Dr. Kaplan putting these in. And we are thankful that it's being done. So initially, it does appear to be a team associated with public health that are going in to do these vaccinations. And so if you're part of a long-term care facility and eventually retirement home, it is more likely that you'll have someone else coming into your organization to do the vaccination. They have their own public health medical directive. They'll have their own staff. They'll have their own training. I hear they even have their own PPE. And I'll be finding out in about 50 minutes how that goes. But certainly we ask for a lot of help from our long-term care physicians, nurse practitioners, and allies. Because while they're going to be able to handle the EMR and the vaccine administration, they're not going to be individualizing. And so, I like to say to people, the people who say everyone should get vaccines, I put in the same group as people who say no one should get vaccines. We want to make sure we individualize this just like we do in the clinic. So I call on a lot of our family physicians to do that individualization, review your residents, review your patients. And make sure that we're putting the right precautions in place. There are some, contraindications, which are quite rare, to be honest, but there's some special considerations where we can help guide, and certainly found that it gives a lot of confidence to family members as well, knowing that that can take place, because there is a lot of fear out there and a lot of concerns. It's nice that we do have a bit of advance warning in some places. So if you're not getting the vaccine today, I encourage you to connect with whichever staff that you have there and start working on that to make sure that your residents are given that opportunity to have the confidence that this is guided by their physician. It looks like it's predominantly the Moderna vaccine, though we're hearing rumors that they're going to be able to try and support Pfizer finally. And really, it's whatever it takes to get those vaccines in those arms. From here, I certainly encourage those who are associated with retirement homes, and I think that's probably about 90% of family physicians with a general practice. Probably we all know someone who's in a retirement home. They're eventually going to need similar supports as well. So consider reaching out to local retirement homes, offer your support. That individualization is really key. Again, we're really hoping and praying that this is going to get into the hands of family doctors to administer, but in the meantime, while there's this rush, please offer to help as you can. And of course, I still truly believe that every retirement should have a medical director. So this is a great opportunity to build that relationship, to show them that you help, that you care, and that you can really help them in crises. And of course, you're always welcome to encourage them to hire you on as a medical advisor, a medical director. And it'll really help improve the quality of care that's given. Really appreciate it. Again, really hoping to get those vaccines into the hands of family physicians soon, but any help you can offer is greatly appreciated. The other last thing we'll get into as well is around the hesitancy from staff as well as family members too. And so we'll discuss a little bit later, but one of the things I loved from session 1, and I'll continue to love from session 2, is how eloquent people are speaking today. You're going to hear some really great answers. I jotted down lots of answers last session as well. Hearing it directly from really spectacular experts that just have really nice and kind ways of sharing their knowledge. So this is a great chance to empower you all and encourage you to become vaccine champions and have the confidence to guide your local area.
Thanks so much, Hugh. It's been great to see family doctors take Moderna into the long-term care homes and retirement homes and vaccinate, and the support of the family doctors who are longitudinally caring for those patients, having those individualized conversations. So, I think some of this session is to answer your questions in order to have these individualized conversations. I'm going to just start with some of the Q&A and then go back to our panelists for further discussion about hesitancy as well. So I think, one of the top questions right now is, we want to support other people to get the vaccine, but of course, we want to also get the vaccine ourselves. So David Kaplan, I wonder if you could answer the question about when might community doctors be getting the vaccine for vaccinating the general population, and then when will they be getting the vaccine for themselves?
Sure, no problem. Maybe we could bring up that slide. Is that possible?
Yeah. So Brian, could you bring up the COVID-19 vaccine distribution plan slide?
Shouldn't say it's my slide, it's a government slide.
So it's going to just take a couple minutes.
Yeah, no problem. So while we're bringing up that slide, what I'll say is that the government has released, I guess, 2 days ago, an update on its plans to vaccinate specifically the 8.5 million people in phase 2 of the vaccine plan. So in phase 1, as many of you know, the beginning part of phase 1, but all of phase 1 is going to see about 1.5 million people vaccinated, with the first doses, as Hugh said, really needing to go to the resident staff and essential caregivers in long-term care, in a retirement home. Very interesting numbers needed to treat in long-term care in the UK is 20, which is pretty amazing. So you need to give 20 vaccines to save 1 life in long-term care, in the data coming out of the United Kingdom. In group 2, those are going to be older adults, beginning with those 80 years of age and older, and decreasing in 5-year increments over the course of the rollout. Individuals who are living and working in other high-risk congregate settings. So this would be like shelters, for instance, or group homes. Frontline essential workers, so this first responders, people in education, food processing, industries where we know there's a lot of transmission and workplace outbreaks. And then individuals with high-risk chronic conditions and their caregivers. So specifically, I would probably say all of us on this call who are family physicians and our staff should be able to expect to be vaccinated, I would say within the next 6 to 8 weeks. Phase 2, which is that broader population, the 8.5 million people, in addition to the first 1.5 million, the government is aiming for the end of July 2021. Now, I think we have to realize this is all based on 2 things. First of all, there are only 2 vaccines that have been approved by Health Canada. And as new vaccines come on board and we have access to more doses sooner, this plan could be accelerated. And then the second thing is also, this is all based on what the federal government has currently announced to the province, what to expect, like how many doses of the current 2 vaccines to expect. And if the federal government should make an announcement that they have found an ability to get more Pfizer vaccine or Moderna vaccine quicker, obviously this schedule could be accelerated, because the majority, the rate limiting factor here is vaccine availability. In preparation for this larger phase 2, obviously we're gonna need to add more vaccination sites over the coming months. Those sites are really going to be for Pfizer, municipally run vaccination sites, hospital sites, mobile vaccine sites, large clinical settings, community settings such as community health centers and Aboriginal health access centers. In fact, the City of Toronto in 3 days from now is going to be opening a test run at the Metro Convention Centre. It's going to be administering vaccines to people who are in the phase 1 priority population, and it's going to be really an ability to do some PDSA cycles and create this proof of concept for municipally run vaccination centers. So I think that's what we know currently based on 2 vaccines and the existing supply of those vaccines. And then specifically with us, family physicians and nurse practitioners, I think it would be reasonable to say 6 to 8 weeks, we should all be vaccinated. That being said, if any of you are going out to do vaccines in high-risk areas like retirement homes, many of the public health units will help ensure that you yourself could receive a vaccine because you are working in a higher risk setting.
Thanks, David. So I think you clearly answered the question about when family doctors could expect to get the vaccine themselves. Just to clarify, is there any plan for family doctors to be getting the current vaccines that are approved, so the 2 mRNA vaccines, or are we really going to need to wait to have the approval of the J&J or AstraZeneca vaccines in order for us to deliver in our offices?
So I think for us to deliver into our offices, we're going to have to, in individual offices, in the same sort of flu shot model that we've been doing, we're going to need to wait for a vaccine that's easier to transport, like the J&J vaccine. That's not to say that large clinics may be supporting your offices. So I can imagine if there was a large clinic with the appropriate space being a hub for a community. And Noah wasn't on the call, but I, along with some others, had the opportunity to learn directly from the Israelis with the science table, the provincial science table, about how they did it and how they were actually breaking up larger pallets of Pfizer vaccine. They've created with Pfizer this lovely pizza box delivery service that has smaller quantums of vials of vaccine to get out to other areas. So while they have, I think, 18 or 20 sort of freezer sites in Israel, what they've done is they've actually split up those and got to even communities of only 100 people by breaking up that. And I could see that being hopefully a way to get Pfizer into larger community-based settings.
Mm-hmm. So in the as far as we see right now, family doctors have a big role in obviously counseling our patients and also supporting larger vaccination efforts, but probably not in our offices at this moment, although it's hard to predict the future. So I'm going to turn it over to you, Zainab, for a couple of other questions. Or actually, before I get to you, maybe I'll take this next question. Part of it, we want to get everyone a first dose as quickly as possible. And so there is a new guidance, I think, from NACI about whether we can delay the second dose so that more people, for example, can get that first dose. So I wonder if one of you could comment on that. Eileen Comerton asked, can you comment on the Quebec model for now using the first dose and delaying the second dose? And I believe NACI came out with a recommendation. Noah, I'm going to pick you. Can you answer that question?
Yes, sorry, I was on mute. And I was typing furiously. There are so many questions. So the 1 dose, 2 dose issue is very, very complicated. It's a function of trying to get some amount of immunity in as many people as possible versus getting more certain immunity in a more constrained population, right? And that kind of weighing of what to do will totally depend on our supply. So if we were awash in vaccine, we wouldn't have to think about making compromises. But for this very moment, when supply is uncertain, and people are dying, it can feel quite sensible to wade into the waters of the unknown. And that's what people are thinking about doing. Truly, though, we don't really know how protected people will be with just one shot. We have like sort of extrapolated interpretations from the trial. But if you're sort of a traditional trialist, you take the result of the pre-specified primary outcomes from the trial, and that is the result. So
my understanding is as well, though, that NACI did say,
Tara, is that the pharmaceutical companies, as I understand it, are very concerned that if people sort of deviate too far from the protocol, the results may be less good than expected, which is a reasonable concern. And as a result, that might affect their future sales, I think. And so they really don't want people to deviate from the protocol for those reasons, which kind of makes sense to me. And so there's that to consider as well. So there's the risk that if we deviate too far, it might sacrifice our future access to supply. All of this is well above my pay grade, and I don't envy the folks needing to weigh these things out. It's really like completely uncertain.
Mm-hmm. My understanding, though, that NACI did come out with a guide that said that it can be delayed up to 42 days.
Yeah, it's worth saying that in the trial there were there was like an allowance for at least a week beyond the plan. So that's not a problem to go from 21 to 28 days, and in the Moderna trial to go to 35 days. And NACI has said it's fine to go to 42, and most scientists say it shouldn't be an issue really to delay farther. But to just say we'll get to it in 6 months is like we're wading into the unknown.
Right. Thanks, Noah. So maybe I'll go to you, Zainab, next. I think there are a number of questions just about people who are immunocompromised or taking immunosuppressants. So one popular question is, do we stop certain medications like Imuran or methotrexate or biologics when we give the COVID vaccine?
Okay, so in terms of those who are immunocompromised, the various different societies who see these patients have put out guiding statements indicating that these patients should be vaccinated, and they do support vaccination in these groups. So for example, some of the biologics you mentioned related more to GI, related to IBD, they actually have a statement. It's in that kind of, you can link to it from the guiding document from the Ministry of Health, which I've shared, I think, in some of the questions, and I'm sure we can share again in the chat. It actually has links to those specific societies. And with, for example, the GI one, just kind of looking at some of the stuff with Imuran and such, they recommend it for stable IBD patients, but they also suggest it for their patients. They haven't given any indications that this should be stopped. I think that if we're talking about certain ones, like, very kind of heavy ones in terms of something like oral steroids, we may need to look at that. But I think that for some of the biologics, those they're typically given in intervals. So at this point, I don't think that we're recommending any kind of stopping specifically, but I would recommend look at the specific disease states, because we use all these different immunosuppressants differently in each disease state, and then look also at the recommendations from that specific group. So there's stuff from the Rheumatological Association, stuff from GI, because it also depends how we're using them. So it's not like a general easy statement, but most of them are just recommending to proceed with immunization in these groups for the immunocompromised.
Thanks, Zainab. I'm going to do a follow-up, and Brian, maybe while we're doing the follow-up, I'll get you to bring up that slide just about the vaccines in immunocompromised, guidance for immunocompromised persons. But while Brian's doing that, I'm going to ask Zainab if you could speak a little bit to the next question about Guillain-Barré. So patients who, with a past history of Guillain-Barré, can they receive the COVID-19 vaccine So there's a couple of questions like that. And so maybe you and or David Kaplan could address that.
Sure. So, Guillain-Barré is only a contraindication specifically for the influenza vaccine if you've had it Guillain-Barré occur within 6 weeks of your prior influenza vaccine. Aside from that, Guillain-Barré is not a contraindication for vaccines and has not been indicated as a contraindication for the use of the mRNA COVID-19 vaccines. I don't know if you have anything else to add to that.
David,
no, I'm just, all I'm doing is I'm posting the CDC guidance, so in case people want some backup that they can keep in their chart or something that they're worried about, that it's there from the CDC.
And I also posted the one from the Ministry of Health that has the special populations. I posted in the general chat as well. So,
Yeah.
and that addresses immunocompromised as well as other special populations, those with allergies, breastfeeding, lactating. That's a great thing to have kind of to refer to at all times.
So that's this guidance that we cut and pasted onto the slide here. As Zainab mentioned, there are the links to specific societies. And maybe if we go back a slide, Brian, the same guidance also talks about pregnant and breastfeeding women. There were some questions about pregnant women and how to counsel about that. So, I think this is actually a copy of a consent form that we developed at our institution. And I had the opportunity to actually review with patients myself this week in the vaccine clinic. And essentially it goes over, the fact that we don't have trial evidence for people who are pregnant, but at the same time, there are known risks of getting COVID and for COVID being more severe in women who are pregnant. And so that every person needs to really weigh the benefits and risks of the vaccine for themselves and make an informed decision. And I think this consent form, although quite dense, it does present the evidence that is available. So I wonder if anybody else wanted to comment on kind of the counseling of pregnant or breastfeeding women and other people who may have been left out of the trial. Zainab, maybe I'll turn it to you.
So I think that this really was kind of well stated by the SOGC. Unfortunately, what happens when we do these trials initially is that, unfortunately, pregnant women often are not included in these initial trials, similar to potentially breastfeeding. But from a theoretical standpoint, our biggest concern with vaccines specifically in pregnant women is live vaccines, the potential that, if you develop an infection while you're pregnant, you could suffer, a vaccine strain infection, but even though you might not get, terrible consequences personally, but if you get sick, when you're sick, this can definitely affect the fetus. In addition, even with vaccine strain, certain viruses that could still potentially affect baby and have various effects. So that's kind of the concern about infection in pregnancy. So for some of the live vaccines, we obviously hold off on some of those in pregnancy. This is not a live vaccine, so there's not kind of that risk for pregnant women. In addition, there's not a concern. mRNA is going to actually be degraded. Doesn't go backwards, doesn't get incorporated into DNA. It will not affect the baby's development from that perspective. Actually, that part, they actually won't see the mRNA, that should be degraded, and they'll just hopefully get the passive antibody from mom to baby, which hopefully will be helpful when they come out into the world where they may be in contact with COVID. Breastfeeding, to be honest, we don't really have a lot of contraindications for vaccination and breastfeeding patients per se from, aside from maybe that kind of theoretical concern about live vaccines because baby's immune system is not quite as robust as ours. But actually we do know there's still some immunoglobulin transfer from breast milk. So hopefully that would actually be helpful in terms of some of the protection that's going from mother to child as well. So it wasn't formally studied, but the concerns in pregnancy and lactation should not be an issue when you're looking at it from a science perspective in terms of the reasons why we hold off on some vaccinations in these special populations.
Thanks, Deb. The same guidance document has information on breastfeeding and pregnancy, and as mentioned, that's been posted in the chat. So, Brian, I'm going to turn over the conversation to a little bit more about vaccine hesitancy, or as Sarah Newbury said to me, we should be talking about vaccine confidence, actually, which is sort of the positive aspect of or corollary to vaccine hesitancy. And Brian, I wonder if you could bring up the slide just before PROTECT, the one where we have some graphs about vaccine hesitancy. Because we know that overall, there have been different polls done, and now, we know that in the general population, actually, many people are excited to take the vaccine. This most recent poll that's in the bottom right actually found that there wasn't that many Canadians said that they probably wouldn't take it or definitely not take it, which was good. And I think that's been changing over time. Although at the same time, I think we're seeing hesitancy among healthcare workers themselves. And I think some of the top concerns, this is from a Statistics Canada report done a few months ago, but, people not having confidence in the safety or concerns about risks and side effects. Maybe they don't think that the vaccine is necessary for themselves. So those are some of the concerns that people have. And so I'm just going to maybe turn it over to Hugh to start. And Hugh, you've been having a lot of conversations both with residents and with staff in long-term care. What's been your experience around hesitancy, and how have you helped to build vaccine confidence?
Well, this is something that has taken quite a bit of effort. I was really surprised with our homes where I recommended client-facing staff first crack at it, those who have the most frequency, and as physicians we're there once or twice a week, a little bit later, and surprised that I was offered a spot within the first week, and so was asked to do it, just to at least show confidence that the others can get the vaccine safely. So what I've been liaising with lots of people, liaising with NPAO, Nurse Practitioner Association of Ontario, liaising with Ontario long-term care clinicians, and with Dr. Ivers to kind of talk about different approaches in different areas of addressing this. So in my homes, I've been hosting town halls, Zoom meetings like this, or exactly like the 850 people we have here. We have a little less, and we just chat, we talk. We have developed, I've got a little presentation and slide deck, and Noah and I, as well as Dr. Robert from the Ontario long-term care clinicians, have kind of fine-tuned it along with consultation with the Nurse Practitioners Association of Ontario to make sure that we're all comfortable. We have a kind of backup to host these events and to chat with people. And those presentations do a lot to kind of make it clear that we're listening, we hear you, and that there's some really good questions, really good concerns out there. Because hopefully all of us have had some questions and concerns about how fast did this get out, and is this going to be safe? This is a healthy thing to question. And so hosting those kinds of events really, I think, helps validate people's concerns and worries, and changes it from hesitancy to really good questions, because really good questions have really good answers. And getting a trusted source of those answers is really where I think physicians and nurse practitioners can play a role.
I brought up the slide actually of the presentation that you mentioned, in case you wanted to show people that.
Sure. So this is the presentation Dr. Ivers and I put together, and we do have support from the Nurse Practitioner Association of Ontario and the Ontario Long-Term Care Clinicians. We're going to be sending these out to those members. A huge thank you for this community of practice who's agreed to post it as well, so everyone can access it. It's editable, so those in your clinics, you can even take out LTC/retirement home staff and you can just give it to your own staff. Of course, play with it, edit it, do whatever you'd like to do. It's just a format to provide some structure to it. It's really based on the PROTECT document that Dr. Ivers will talk about. Yeah, Alan, it's going to be shared. Absolutely, I promise you. And we'll move to the next slide.
Brian, maybe?
And we'll just quickly burn through these quickly, because it's not about content. This is just talking about, we're hearing you. Good questions are out there. These are good questions and we've got good answers. Next slide. And so we really encourage people to reflect on their own experiences. Again, we're all human. So people with big degrees are having, as we're seeing today, similar questions to people who have 3 to 6 months of education. So it's a good reflection to think about your feelings, your own emotions, and how you then tackled those challenges to get to that point of confidence. Next slide. And then talking about why the priorities are there. Again, this is generic. You can change it based on which location you're at. Next slide. And then, of course, the big question, everyone's top concern about mRNA and is it going to change your DNA? And Noah has this great, he loves the spike protein phrase, and I've come to use it a lot more as well. So we're not giving you COVID. We're not giving you part of COVID. We're giving you this protein. And that's about it. And talking about cell biology, you can talk about the nucleus being walled off and protected. The DNA is safe. This just targets the ribosomes. But really making it clear that you've heard this and you're not brushing it under the rug. Next slide. Talk about the effectiveness is really key. Next slide. Validating that this is safe. About, we've got 74,000 people who've gone through the trial. We've now had hundreds of thousands of people worldwide who are getting this, and this is great. And then really re-emphasizing it's not going to change your DNA. Next slide. And then I like going over the approval process because it was rushed. Don't lie to people. Don't tell them that it wasn't rushed, but point out where it was rushed. It wasn't the safety stuff. The first part that Health Canada got the data regularly rather than waiting until the trial ended and then they put it together and then they looked at it. They got it through. And so they could ask questions. They could pick through it and be critical throughout it. And that was brilliant. They also skipped that time to make sure that this vaccine can sit in family doctors' fridges for long periods of time. That's unfortunate. That's why we can't give it to primary care right now, but it means that we got the vaccine out quicker, but the safety wasn't. 10 times larger. Noah was saying typically 3,000 to 5,000 people. We had 40,000. We had 30,000 people in these trials, which is just amazing. Next slide. And then talking about the long-term effects. Nurse Practitioner Association of Ontario really wanted us to emphasize the peak immunity achieved 7 days following the second dose. We got to get you not just to the first dose, we want to get you that second dose. Next slide. And then I think it's really key to not, sweep things under the rug, make it clear who shouldn't get this vaccine. And as we're seeing that's going to be a really minority. And in my nursing home, it's been nobody. But having those conversations and making it clear that those that we don't want, and then on the right side, those special circumstances where you want to watch someone 30 minutes, you want to put some firm pressure on their arm, things that can help mitigate that risk, talking about providers about, do you delay it so that you can get in contact with an allergist, or is the risk in your area too high and you need to get on this quicker? Having those healthy conversations. Conversations are so healthy. Move to the next slide. And again, encouraging conversation throughout this, encouraging good questions, addressing their questions, because those specifics are key. I heard questions that I hadn't heard about before, and it was amazing to hear them because I thought I hadn't thought about that, but I did read about it. And then go to the next slide. As we see with Protect, it's good to end on that where to go from here. Because good questions have got good answers. Now let's jump to action. Don't leave them asking about questions, leaving them know exactly where to go to get that vaccination. And that seems to help as well. And that's the end of the presentation. We're going to share this all over because we need champions out there. Vaccine confidence is a great thing. It feels great to get that vaccine. It feels great to be part of historic moments like this. And we really need as much help as we can. That hesitancy has been there for a bit. And while, we're not seeing huge public health campaigns that I would have loved to have seen, I think family physicians and nurse practitioners, you can be those champions, and we really desperately need your help. I am sending a lot of staff to talk to their family docs because they have unique health concerns, and we respect that, and individualized conversations are really healthy. So you're going to hear some questions from your own patients who are also long-term care staff. Thank them for their awesome work because they're doing great stuff out there, but also address their really healthy concerns. Thank you.
Thanks, Hugh. Yes, we're in a privileged position of trust where we have long-term relationships and people value what the advice we give. So we all have a role to play. I wonder, Brian, if you could go to the Protect slide, and maybe I'll just turn it over to you, Noah, to just go over this model for how we can try to start to build vaccine confidence and address people who have questions.
Thanks, Tara. Hi, everyone. There are lots of models out there for how to talk to patients, and I do not need to tell my fellow primary care professionals how to talk to a patient. You know, this is what we do. But conversations about vaccines can get unnecessarily heated and may not be as effective as we hope them to be without following sort of a framework. So that's what this is meant to offer. The idea is that, you know, we try to put an acronym to it. So PROTECT stands for, you know, proactively offer them a presumptive statement. So that means go ahead and say to them right away that, yeah, you got it, or you're going to get it, God willing, sometime very soon for all of us. And, you know, you're here to help make sure that they get it too, to protect them. As soon as you have the information, you'll pass it on to them about how to do that. The O is to, you know, offer whether they want to hear from you more about the vaccine. And the T is to tailor. So you could say something like, you know, Mrs. Jones, I'm really keen to get you protected because I know that you work in long-term care homes, or because I know that you live in a multi-generational home, or something that you know about them that either puts them at an increased risk of transmission or acquisition of COVID, or having adverse effects from COVID. Obviously, we all like recommendations to be personalized to us. And to the extent that we know our patients, we can do that for them. Only then should we say, yeah, did you have some concerns and questions? Lots of people do. Are there some that you want to talk about now? So that's the C of concerns. And then you want to shift from answering those concerns. Hopefully you feel after this a little more ready, or at least know which resources to go to answer those questions that come up. And then you want to talk through a specific plan. All right, as soon as I have the information, it's going to be released to you. You can always come to me for more questions, and I'm going to help make sure that you get vaccinated. So it's sort of a circular conversation that starts with saying, you know, I got vaccinated, I want to help you too also. Circles round to the plan at the end saying, all right, so now that we've had this conversation, we can go ahead with, you know, coming up with a plan as soon as we have the details for you. So hopefully people find that helpful to frame things. It's informed by motivational interviewing concepts, things that we all do in our practice anyways, just meant to give you a bit of structure that's based on some evidence around building vaccine confidence. Tara, are you still there? I'll just also say that a more nicer version of this lives on the CEP website. My graphic design skills really suck, and I'm sorry for that.
You made most of the slides in that presentation we just showed. You're pretty good at it. You're pretty good.
Well, I must have been tired the night that I made this slide. I wonder, Zainab, there's a bunch of questions about immunity on the question forum. There's the ITP issue. There's a question about transverse myelitis and what to do, and also maybe a reminder for people about how they figure out whether somebody may be allergic to PEG. And I wonder if we can lean on you for those answers.
Okay, that was a lot of questions.
So I am not as good a moderator as Tara. I'm so sorry.
Okay, I'm going to try to remember all of these. So in terms of immunity, so with the studies, we did look at reducing COVID-19 infection, and that was shown, and that's kind of the 94 and 95% that we quote from Moderna and Pfizer, respectively. In terms of immunity, we're actually still going to be following patients and seeing over time. So it's not unusual that, you know, you're going to reassess how long immunity lasts, and this is going to continue to be reassessed to see if this is going to be something that's more of a yearly vaccine versus than a one-off. So I think there's more to come from that perspective. And I just want to point out, this is not unusual. For example, we've had the vaccine such as MMR around for quite a long time. And actually it was years, like decades later, that we realized, hey, we noticed that some patients are actually developing infections to these. So they're not getting that long lasting, robust response we thought they were. And then we added it and we changed it from a 1 dose to a 2 dose. So that's not unusual that after a vaccine's been out for a while that we actually sometimes revise the scheduling for it. Similarly, if you look at PDSL, that actually has also changed because we realized we could get away in terms of actually spreading it apart a bit. So not unusual, we're going to be following it and there'll be more recommendations as we go. So that's kind of the response from an immunity standpoint. And okay, then in terms
one
of-
was, yeah, ITP and maybe from there, other examples of people like who had other conditions like transverse myelitis and things like that.
Okay, so in terms of ITP, there's actually, there's a statement from, I believe it's PDSA, and I'm not gonna remember exactly what that stands for, but it is actually a group that is focused on some hematological disorders, autoimmune hematological disorders, and they actually have a statement on ITP recommending that patients with ITP get the COVID-19 vaccine. I know that there was one physician in the States who developed ITP several weeks after the COVID-19 vaccine, who unfortunately did die from this condition. That is still being investigated. Causality has not been established. We're still waiting for further reports on that. I do want to point out, though, we have seen ITP in association typically with viruses, right? So we know that viruses may play a role in the development of ITP. And so when we actually look at some of our live vaccines in the past, namely looking at MMR, we actually did see that you can rarely get ITP sometime like 6 weeks post MMR. I think they showed it something like 1 in 100,000 or even less. So that's there. And despite knowing this association, ITP is not a contraindication to MMR. And so I want to point out in the studies, they did not see an increase in ITP. We've seen this one case now. So we've seen it in association with another one. It's not a contraindication based on kind of what we know at this point and from the societies involved. There's still a recommendation for patients with ITP to get this vaccination. If you are concerned or your patient's really concerned, also talk with their physician who's managing their ITP, who's involved with them, or if it's hard to, I don't want to delay things, you can also get an e-consult from hematology on this too. So, but generally though, it is recommended, and I see it's now in the chat with the PDSA recommendation that those with ITP should get it. And I think, did I address those all? Oh, yeah, then there's a thing about PEG. So if I could ask for my PEG slide to come up, please. So here's the thing about PEG. Okay, don't ask anybody if they have a PEG allergy because nobody knows if they have a PEG allergy unless they for sure have a PEG allergy. People who have a PEG allergy know it because they have to avoid a ton of medications. So if a patient is not aware that they have a PEG allergy, asking them is not just directly about PEG is not as helpful. You want to ask them about typical medications they use. PEG is a very commonly used stabilizer as well as a commonly used laxative. So if anyone of your patients, especially I got a lot of questions about older patients, a lot of older patients have had colonoscopies and they have to go through a prep with either Laxaday, Go Lightly, Picostalax, all of these are PEG solutions. So if they've tolerated that without issue, then we know that they do not have a PEG allergy. PEG is also represented in extra strength Tylenol or Tylenol Easy Tabs, the red ones, Tylenol gel caps. It's also in my least favorite medication, Benadryl, 25 and 50 milligram, those pink ones that are everywhere and people have in their purses. I've already mentioned the laxatives. It's also in Reactin, 5 and 10 milligram tablets. It's in Advil liquid gels and in Enteric-coated 81 milligram aspirin. So these are just common things. I've just put the really common ones that I think in primary care your patients are going to use. And these are things that are over the counter, people are using all the time. So it's best to kind of ask them about these, like, are you using this? So that's kind of more important in terms of sorting that out. So then you know if they've had PEG exposure so that you're not concerned from that perspective. People who have PEG allergy, it's extremely rare. And they seem to have like allergic reactions to multiple medications that are seemingly very much unrelated. So they'll react to, an Advil, they'll react to a Tylenol, they'll react to another random medication that happened to be stabilized in the tablet formulation with PEG. Or they'll be very confusing where they'll have like an Advil regular tablet, no problems, but then have a liquid gel and have a reaction. So these ones tend to have seen, and they're often seen by drug allergists. So like some of the drug allergy clinics, I'm talking about like different ones, like you'll see them in the kind of hospital academic centers who focus on this. And there's actually very few. We were actually talking amongst ourselves, like who has PEG allergy patients. I personally don't have any, but some of the people who primarily work in drug allergy do. And even when we talk about, some people are concerned about people with previous reactions to vaccines, the question is, I tell everyone, ask them first about PEG, clarify the PEG, and then for sure ask an allergist. E-consult is super fast, or if you're able to talk to one more readily. And often the first question, if you ask me, the patient had an anaphylaxis to a vaccine, should they avoid it? My first question to you will be, are they taking any of these PEG containing medications? So because, and the concern about vaccines is some of them may also have PEG in it. So we're still going to come back and ask you about these medications. So start off with these ones and check. These are very common and most people are using them or have used them without issue. So I think I might have gotten all the questions, but Tara, tell me.
And sorry that my internet gave out and that I ended up not being here for a couple minutes. So I just wanted to, we only have a few minutes left. There are a number of questions about what our elderly patients and people who are not in long-term care retirement homes, but are homebound and in the community. When will they be able to get the vaccine? And I wonder if either Hugh or David, you'd be able to speak to that.
I think Hugh was going to answer that. I saw from
sure, and I'll, if we can pull up Dr. Kaplan's great slide. Thanks, Dr. Abdur.
Can we pull up the COVID vaccine distribution plan slide, Brian?
I love hearing you chat. So yeah, so on this, it's a great point. So we are learning so much about the vaccine and how to get out to people. So in a lot of ways, I know we want this out. We all have those patients who are high risk for dying of COVID. Absolutely. There might be the focus on those who are in congregate settings who are forced to interact with other people. So please keep encouraging those others to isolate. But all the things we're learning how to get out there, we're hopefully going to be able to use that same machinery to get it out as well. Again, also hoping to get vaccines in family doctors' hands, arms and hands. But this machinery will be hopefully used to target those other high-risk populations. And really pleased to see that we're looking at trying to take that institutional racism that exists and try to break that down at least a little. Share power, share organizations, share resources, and try to get it out to people who really need it most. This is a nice slide to see. We're seeing the kind of different ideas, the hospital clinics, the on-site clinics, and the mobile sites. And so in the future, there likely will be options for how to get your residents those vaccinations and that individualization and trying to figure out what's the best for them.
Mm-hmm.
Yeah, and you can see just because Hugh brought up the slide, in phase 1 in the green bar on-site clinics, you can see adults who are chronically receiving home care. So we know these people are at risk because they have workers coming into their homes and they're a little more, they're moved up from the general population who's 80 and above, for instance.
Thanks, David and Hugh. A couple other things. So I think there have been some questions about if I have COVID, if we've had COVID, when can we get the vaccine? And so I just wonder if we could clarify that for folks. My understanding is that anyone who has had COVID can get the vaccine as long as they are not asymptomatic. As long as they are not symptomatic. There's a specific question. I suppose if you had an asymptomatic COVID, you have asymptomatic COVID, can you get the vaccine? So who here wants to take that question? Noah, do you know the answer to that?
I was answering typing. Can you repeat it?
I'm happy to answer because we've had that situation in long-term care frequently. And so unfortunately, there's slightly different advice. I know Public Health Hamilton is saying wait 90 days. That's garbage. Sorry, Alan. as he posts it. So no, I think we can't afford to do that. I think we know that you can get infected twice, and we know that this vaccine may offer additional things. So I know we've heard Dr. Farsi say that the day after your symptoms resolve. I think a bit of judgment should be taken place around, you're not having active symptoms. You absolutely can't have those active symptoms, because what if you get a fever? What if you get the muscle pains? Is this worsened COVID? Do we need to send you to the hospital, or is this the vaccine reaction? So individualize everything, make those judgments, and have those conversations with their decision makers so they're on board as well.
Yeah, sorry, I answered this a few times in the chat as well. So can wait 90 days if you want. Certainly you should wait, because you'll probably be immune for 90 days. Certainly you don't have to wait that long. Definitely should wait until you're asymptomatic or reasonably asymptomatic.
Thanks, guys. So, what we see here, I think, through the chat is some people who really desperately want the vaccine and can't get it, and others, I think, who need to be getting it and are having some hesitancy because of some good questions. And so I think thank you to our panelists for looking at that. Just as we end, I might just, Brian, put up, if you can go to the protect slide, and after the protect slide, there were just a couple of things that I wanted to give. We're going to share it with our everyone afterwards. So if we go to the after the protect slide, next slide. So if you haven't seen the Center for Effective Practice website, please go on it. There's a great set of frequently answered questions that patients have, and I encourage you to take a look at that and also use it as a handout or guide for talking to patients. Next slide. I think there are a number of now great infographics that have come out, and we'll share these with folks if they're helpful. So this one is from the South Asian COVID Task Force. Next slide. This next one is from Unambiguous Science. So it's really trying to pull together some myth busters from common questions that people have. And next slide. And this one is produced by the University of Waterloo, Kelly Grunwald, and it talks about some of the big myths that are out there. So we hope that we've answered a lot of your questions today. I know certainly our panelists have. So Brian, we can go to the second last slide of the deck. If you want to stay on and take a look at the answered questions, many of your questions may have been answered in that Q&A box already. We will try and summarize some of those and send it out. And of course, our recording will be available on Monday. If you have colleagues who missed it, or if you yourself want to watch the session again, it is eligible for main pro credits, even just watching the session after the fact, which will be posted on our website on Monday. Next slide. I wanted to draw your attention to the fact that we do have a next session on January 22nd. So that's just next week. We know there's so many questions about the vaccine, and so we've decided to hold these more frequently in order to answer. So we'll have one on January 22nd, and again, probably 2 weeks after that. The next one will be with a different round of panelists, but also focused on the vaccine. So I wanted to thank all of you for the continued wonderful work that you do, and of course our panelists for their time today in answering your questions. Thank you, and stay safe.